Good afternoon, all. Welcome to the RDLS session. Today's RDLS session will be taken by Dr. Harshita Gosainwal, Medical Officer, pCoE Kalavati Saran Children's Hospital, on the topic Pediatric SACEP Referral the Right Way. Now, I would like to request Dr. Harshita to take the session.
Hello. Hello. Shweta, am
Ma'am,
I
you're
audible?
audible. Yes, ma'am,
Oh,
you're audible.
okay. So I will start the session, Shweta, then, or
Yes,
there are
please.
more people to join.
If you want, we can wait for another 2 minutes. We have already circulated the link on WhatsApp groups as well. So we
Okay.
can wait for another 2 minutes and then start, ma'am. Is that okay?
Yeah, it's okay.
Yeah, thank you.
Visible to all?
Yeah, yeah. Screen is visible, ma'am.
Okay. Good afternoon, everyone. I am Dr. Harshita, working as a medical officer in pCoE Kalavati Saran Hospital. Is very where I'll take a pediatric SACEP referral the right way. How to put a SACEP and when to do it and how can you do it? Because it is a very important part. So I'll start my session. Am I audible to all?
Yes, ma'am.
Okay.
Ma'am, you're audible.
Okay. So in the session, by the end of the session, the participants will be able to understand the PSASER, that is Pediatric State AIDS Clinical Expert Panel, and what is the need for a pediatric PSASER, determining a treatment failure and referral of the CLHIV for PSASER. We'll understand about the PSASER referral mechanism and the checklist, how to make it. Steps to be followed for SACEP in COE or pCoE and formats to be maintained. And we'll discuss about the gaps in referral mechanism and then we'll discuss upon the key points. So what is a PSACEP? PSACEP is basically a pediatric state AIDS clinical expert panel. In PSACEP panel, we'll have a nodal officer of COE or pCoE, one pediatrician from pCoE, and a senior medical officer or a medical officer of pCoE or an ART center. So there are 11 center of excellence for PLHIV and for CLHIV, the pediatric center of excellence are 7. You can see the list of center of excellence in this slide. There are 11 and pediatric center of excellence are 7, in which the Kalavati Saran is a pediatric center of excellence, which is located in Delhi. So PCSUB at pCoE, it was starting in April 2017. The meetings are scheduled on first Tuesday of every month at pCoE KCH, otherwise the next working day in case of a holiday. Why do we need pediatric PCSUB? The treatment failure criteria in children less than 5 years, it's different from the adult because the CD4 are physiologically higher in this age group. Pediatric diagnostic dilemmas in differentiating between opportunistic infection, iris, and adverse drug reaction in the setting of suspected treatment failure. And also, there is a limited antiretroviral drug options in children. For adult, you also have a limited option for, but for the pediatric, you just have very limited ARV drug therapy options available for the children. So, what are the reasons for PCSF referral? So, in the slide, the reasons are first is suspected first line failure or a second line or a third line failure. In this, the person to be evaluated in person at pCoE KCH or wherever pCoE is available. And patient, we cannot, in person, if the patient is not available, we can talk about the ARV drug toxicity for alternative first line, management of severe opportunistic infection, any drug related complications, and other pediatric dilemma in the management of HIV infected children less than 15 years. Decision for initiation of third line ART shall be taken by the SACEP at COE and pCoE only, or the ART plus center after a e-review. SACS in consultation with COE and pCoE and after the approval from NACO may authorize SACEP or select ART plus center based on their functioning capacity to prescribe third line. So important point to be noted in this is if there is a suspected first line, second line or third line failure, the person needs to be evaluated in person in pCoE. And for the drug toxicity or any opportunistic infection or any other pediatric illness you want to discuss, you can have a e-SESUP or a e-review with the ART center or ART plus center, whatever is available. After the PSASEP, so there is a note, after the SACEP has reviewed the patient and prescribe a third line for a patient, initiation and follow-up dispensation will be done by parent ART center as same for the second line ART. Henceforth, transfer out for initiation of third line is not required. So it is very important, like second line and third line drugs are all available in all ART and ART plus center. So you don't need to transfer out that patient from your parent ART center. The drugs will be available at their parent ART center for the second line and the third line ART as well. So how to determine a ARV treatment failure? So treatment failure is basically loss of antiviral efficacy, which triggers the switch of entire regime. It is not the substitution, it is the switch of the entire regime. The treatment failures are three types. One is the clinical criteria, one is immunological, that is CD4 count or percentage criteria, and another one is virological criteria. So there are three treatment failure which are identified: clinical criteria, immunological criteria, and the virological criteria. So viral load test result, you can you so the viral load test result, if the copies is less than 1,000 or the target is not detected, the interpretation will be virally suppressed and the action should be continue the same ART regime and advise the next viral load test as per the guidelines. For first line patients, it is yearly, and for the second and third line patient, it's every 6 months. And if the viral load result is more than 1,000 or equal to 1,000, the patient is virally unsuppressed. There should be EAC done for 3 months. Enhanced, that is called as enhanced adherence counseling, should be done for 3 months. And the repeat viral load tests when treatment adherence is more than 95 for 3 consecutive months. And after the viral load testing, if the viral load is less than 1,000 or TND, then continue the same ART regime. And if a viral load is more than 1,000 copies or unsuppressed, then the patient should be referred to SACEP, to COE or pCoE, depending on the PLHIV or CLHIV. So, there is a note that in exceptional cases of PLHIV with high viral load and poor clinical condition, ART of MO or SMO may refer the patient for SACEP for further management, even on the basis of a single viral load report. And there is a one more note: in patient with HIV-2, the decision of ART failure is taken based on the immunological failure criteria. These all guidelines are based on the National Operation Guidelines for ART Services 2021. So, as we have discussed, there are three types of failures: virological, immunological, and clinical. From the slide, virological failure is when there are two consecutive HIV viral load more than 1,000 copies per ml with the following criteria. After 6 months of ART initiation, after giving 3 sessions of step-up adherence counseling, and adherence in the last 3 months was more than 95%. So these are the 3 points which we need to remember for a virological failure. For immunological failure, there are criteria for different age group, because children between 12 to 35 months, the CD4 percentage, if falls below 15%, it is not the CD4 count, it is the CD4 percentage, because in CLHIV, we take account for the percentage. And there is a persistent CD4 below 2,000 cells per mm cube after the 12 months of ART. And in the children between 36 to 59 months, the CD4 percentage, if falls below 10%, there is a persistent CD4 below 200 cells. And for the children who are more than 5 years and above, at least one of the following three criteria should be there: fall of CD4 count to pre-therapy levels, 50% fall from the peak on treatment level, and a persistent CD4 level below 100 cells after 6 months of ART. So for a different age group, we have different criteria for immunological failure. And for the clinical failure, we should have new or recurrent WHO stage 4 condition. That is, it is given in the guidelines like extrapulmonary TB or any other infection after at least 6 months of ART, progressive neurodevelopment deterioration, and a growth failure. There is a chronology of the treatment failure. From the slide, you can see the clinical status of the patient is falling down. In this, we have seen viral load, which was initially suppressed. It is going high, which is becoming unsuppressed. And the CD4 count is also initially, it was more than 350, you can say, and it is also declining. So we can, by the time the patient comes in the clinical status of stage 3 or 4, you can say, we can, from the viral load and CD4 count, we can detect it before the patient goes in the clinical failure. So the virological testing is very important. The viral load testing is very important in this. So before suspecting any treatment failure, we should ensure these are the factors you need to consider before defining a treatment failure. The child should have received the regime for at least 6 months. The adherence should be more than 95%. Any active opportunistic infection should have been treated and resolved before interpreting the CD4 counts. The iris syndrome must be excluded. The primary malnutrition that can mimic clinical treatment failure should also be ruled out. The effects of all drugs manifesting like clinical treatment failure should be ruled out. All suspected clinical and immunological failure should be confirmed by virological criteria for treatment failure. So before defining that a patient is failing on this drug, there are 4 points which you need to remember. I will repeat. Like child should have received at least 6 months of ART, उसको मिलना चाहिए. Adherence 95 से ऊपर होना चाहिए. आयरिस हमें रूल आउट करना है. प्राइमरी malnutrition उस पेशेंट को हमें पहले मैनेज करना है, रूल आउट करना है. Any adverse drug should be managed and any OI should be managed. So the growth monitoring. So flattering and growth monitoring is a sensitive indicator of the treatment failure. From this slide also you can see the growth from 1 year, 2 year, 3 year, 4 year, and 5. The graph is showing a growth. It often occurs even before opportunistic infection or other symptoms become overt. A large observational data set emphasizes the importance of growth monitoring in the routine clinical assessment of CLHIV and suggested that the loss of weight or poor weight gain are potential signs of treatment failure. So growth monitoring is done like you do in your ART center. Whenever a patient comes, you do weight, height, you plot their growth charts according to IAP and WHO. These are very important because from this only we will get to know about a failure very early. So the growth monitoring, growth is assessed by interpreting the child's anthropometry. As I said, weight, height, and BMI if the child is more than 5 years of age. These three parameters are very important. You need to check every time. See, there are times when there are patients who are on the proxy visit. Please try to call the patients because the weight, height, and BMI of the child and their plotted growth charts are very important in relation to WHO reference standard for age and sex. The WHO growth reference standards are available as charts and table. They are available online also. And you must be having all the growth charts in your centers also. Serial recording gives a good idea about the child's growth over a period of time. When the child growth parameter falter, a serial recording on a growth chart will no longer be parallel to the standard growth curves. So from the growth curve assessment, you can see like there is for in the first you can see the baby is growing well. So we need to encourage mother to feed as before. There is then in the second one we can see the growth curve which is flattening. We need to have an urgent assessment needed. And in the third one you can see the patient is losing weight. The growth in the growth chart the line it is falling down, so the urgent assessment is needed. So I will request everybody at all the ART center they should plot weight, height at least for the child, because from the growth chart we can easily assess the child is growing well or not. So the growth monitoring, there are WHO Anthro. It is a site. You can download the app. We'll share the link with you. There's a WHO Anthro. Is a software for the application of the WHO Child Growth Standard and monitoring growth of children 0 to 5 years of age. So in this, you can see there is an anthropometric calculator, individual assessment, and nutritional survey. And for the children who are more than 5 years of age, there are Anthro Plus. So this is in this slide, you can see there are patients, 3, 4 patients we have plotted, and we have put the first name and the last name, the date of birth of the child. You can skip the mother father part and the address. You can get their observed weight, height, edema, and everything in that. And then in the visit, like the patient has been registered with you in the month of April. So there So it will you will have a weight, height, and BMI plotted for that person of that child. If the child is more than 5 years of age, you need to plot the BMI also, and you will get the percentile also and the Z score also for that child. And there is an anthropometric calculator which is based on the growth charts of WHO and IAP. It is designed by AIMS, so it is a very handy app. We can download it from your mobile app from the Android or iOS. We'll share the link for the same also. So, what is the mechanism for referral review of PLHIV by SACEP? E-referral to the SACEP. Patient treatment details should include the ART history, the latest viral load and CD4 result, and the recent investigations if done, the treatment adherence and other relevant clinical details. The reply and referral form from referral and reply are shared by a referring ART center to the COE or pCoE or ART plus center. The SACEP review would be conducted in the absence of patient. Usually, it is better to conduct the session in present of a patient only, because we'll get to know about the patient complaints and adherence or any issues the patient is having. Recommendation of the SACEP should be shared with the referring ART center over email. The note, in certain situations, SACEP may want to review the PLHIV or CLHIV in person. Patient visit the center on the designated SACEP days for the clinical consultation. Preferably, in-person review should be done for PLHIV or CLHIV belonging to the same COE or ART plus center or pCoE where SACEP is being conducted. Tele-SACEP. After following the e-referral procedure described above, ART center and the ART plus COE, pCoE would be virtually connected over the video or teleconferencing. ART center present the case to SACEP in presence or absence of the patient, and a pSACEP give recommendation for further course of action. This will help in reducing turnaround time for SACEP review and need for multiple communication between ART center and SACEP. Providing opportunity for mentoring and capacity building or referring ART center through immediate feedback on patient care by SACEP. Patients requiring in-person consultation can also be reviewed through tele-SACEP, avoiding the need for travel. Considering the benefits, all COE and pCoE and ART plus center are encouraged to conduct a tele-SACEP. So the SACEP referral mechanism. First point is ART center should refer the details of patient in a reply and referral form to the pSACEP through an email. pCoE will review the details provided and provide a date by email or telephonically for physical review and examination of the patient. Patient with the caregiver will be reviewed either at the parent ART center through online mode or at person at pCoE or COE. Second line or the third line ART will be initiated at the parent ART center as per the recommendation on pSACEP, and you don't need to transfer out the patient to the other center because the second line and third line drugs are available in all the centers now. Patient will be followed at the parent ART center itself and referred to the pSACEP for follow-up, which is very important. And many times काफी सारे सेंटर्स इसको भूल जाते हैं कि एक बार पी सेसअप हो गया या सेसअप हो गया उसके बाद वो फॉलो अप नहीं करते उस पेशेंट का. The follow-up should be done with the viral load test after 6 months of second line, third line, or after the pCACEP referral. So this is a very important slide. These are the checklists for preparing a case summary for pCACEP referral. The name should be there of the patient, the date of birth, present age, date, and the age of diagnosis and the place of diagnosis. The mode of transmission, HIV status of the family and or the caregiver, and at the time of registration, the date, age, clinical stage, CD4 count and its percentage, and anthropometry, that is weight, height, BMI with respective Z score should be there in the summary. And continue, the date of ART initiation should be there. The regime started, ART drug history, like any substitution, transition, or any switch, and with its reason should also be said. There should be a history of all the opportunistic infection, adherence profile, anthropometric progress in the form of weight for age, height for age, and BMI for more than 5 years with a Z score. CD4 count profile since the ART initiation with the most recent, that is within 1 month, not 1 year or 2 year back. Should be the within 1 month CD4 count and all the baseline investigations. Any relevant investigation done recently to rule out any opportunistic infection. So these are the main important checklists you need to see before sending a patient for a SACEP referral. The points are name, date of birth, present age, date and age of diagnosis and the place of diagnosis, mode of transmission, HIV status of family and caregiver. At the time of registration, all the anthropometric details, the date, age, clinical stage, CD4 count should be there, the date of ART initiation, the regime in which the patient was started on, any ART drug history like in a substitution, transition, or any switch with its reason, history of any opportunistic infection, adherence profile, anthropometric progress in the form of weight for age, height for age, BMI with their Z score, CD4 count, and especially the recent CD4 count within 1 month, and other baseline investigations. Any relevant investigations done recently to rule out any opportunistic infection. So this is the request and reply form for the review by SACEP at COE, pCoE or ART plus center. In this, that is given in your SOP also, and you can download from IMS also. The request and reply form is ART from the ART plus center or COE or pCoE. You need to mention the date, name of the referring ART center, properly mentioned, center of excellence or ART plus center, where are you referring the patient. These details should be there, the name, ART number of the patient, the age, sex, weight, reason for the referral. There are 4 headings which you need to be mentioning, like no, you need to take one of them. Suspected first line failure or suspected second line failure, any adverse effect or any other which you need to specify. Documents you need to attach is all clinical records, all lab reports, photo documentation of any adverse effects. So there is, you need to write a short summary of clinical history, describing brief major events since ART initiation, any opportunistic infection or any clinical staging of stage WHO stage 3 or 4, the current clinical staging of the patient, any current co-infection or opportunistic infection on any comorbidity if present, concomitant drugs like you give ATT in case of TB, TPT and CPT and hepatitis B and C treatment if given or any other. Type and grade of adverse effect if the child has from the ARV drugs. You need to give the complete ART history, ART drugs, which was the patient initially started on, the time duration for each ART drug regime. So there are serial number, period with date, ART regime, duration, and if there is a reason for change, like a transition, substitution, or a switch needs to be mentioned. The second, in the next line, there are serial viral load testing, which you need to be done, the viral load date, result, and same for the CD4 with the dates. And the latest CD4 should be sent with the SACEP referral. And the treatment adherence, percentage for each of the last 3 months, and the latest lab investigation that you can see like HB, serum creatinine, LFT, blood sugar, and any other investigation done out to rule out the opportunistic infection. And this is the reply that from reply for the SACEP from a COE, pCoE, ART center will give. That is also given in your SOP, the annexure 13. So we'll give the reply in the form of date, when was the PSACEP or a SACEP was done. The ART sent the name, ART registration number, the SACEP registration number, and the SACEP recommendation that either to continue the same regime or repeat the patient's viral load or switch or any substitution with the dosage needs to be mentioned. This is important for COE, pCoE, and ART center that whenever you are there is a switch or a substitute, you need to write the dose also with it. And any other specific recommendations like you need to do the viral load testing or a CD4 count done, and any advice and instructions, and this needs to be taken care. The SACEP tool to be maintained. So the SACEP request and reply form that can be generated from the IMS or you can download from your SOP, that is from the Annexure 15. The SACEP referral summary, the revised format to be generated from IMS, that is sorted by financial year, to be linked with a line list of PLHIV with unsuppressed viral load at all referring ART center. The SACEP register, which is need to be that is auto-generated from the IMS at COE, pCoE, and ART plus center. The CSEP mating format to be auto-generated from IMS or SOCH at COE, pCoE, and ART plus center. The monthly reporting format for third line, no separate reporting required. Third line reporting to be integrated with the MPR. So this is the referral summary line list, which you need to be maintained. This is given in your SOP, the Annexure 5, the line list of PLHIV with unsuppressed viral load or the SACEP referral summary. In this, you can see the format. the serial number, ART registration number, name, age, sex, date of viral load test, viral load count, what was it? It was suppressed or unsuppressed, or whatever the count is. Adherence, which is it less than 95% or more than 95%? And there is enhanced adherence counseling if the viral load is unsuppressed. You need to write the date adherence for session one. For the session two, you need to write the date adherence again. And for the session three, you need to write a date and adherence again. And the step up counseling was completed or left in between or any other reason, you need to write it. And date of repeat viral load test, viral load count. And if it is still unsuppressed, like the second viral load is unsuppressed, the date of e-referral to the SACEP, and date of review, what was the review given for the SACEP recommendations like switch or substitution, continue the same regime, and date the start of second or third line ART if there is. Steps to be followed for review by pCSF for suspected treatment failure. First, step one, we need to define the treatment failure. Either it is clinical, immunological, or virological failure. Define the treatment failure by virological testing. See if the adherence to treatment is adequate. Because many times the adherence is not adequate. Counsel and support. SACEP will see these and take action on providing second line ART. And then the step two is you need to decide on the NRTI component of the second line regime. And in the step three, you need to decide on the third component of the second line regime. These both are same for the third line also. And in the step four, that is very important, the patient education and agreement on treatment plan, including follow-up and monitoring should be done, including counseling for adherence, linkage to specialist care and follow-up monitoring plan. This is the table. You can see the second line ART regime in children. It is given in your national guidelines, and in the app also you can see these are the second line regimes. From this only you can see we have very limited options for the children. And third line is on the third line also you can see this is given in your national guidelines and the app which was launched by NACO. You can see them in that. So in case difficulty in assessment of second line failure, complicated prior treatment regimes, patient referred from private or any multi-NRTI exposed cases, any intolerance to third line drugs, cases requiring these third line drugs are alternative with the second line ART or any other query, SACEP at pCoE or CoE can obtain expert opinion from the National AIDS Clinical Expert Panel, that is NASASEP, by addressing in the following mail ID. So what are the gaps which are found in SACEP referral from ART center? First is incorrect adherence calculation, or sometimes there are adherence which is not being calculated. There are delayed or late referrals, the referrals which are incorrect. There are some inadequate data sent, incomplete record. COE does not receive regular feedback report from the ART center regarding the implementation of SACEP decision for patient review by the SACEP. So the incorrect referrals, many referrals are incorrect because of the following issue. The patient is non-adherent to ART, or there is an incorrect dosage because PLHIV, in CLHIV, you need to give the ART doses according to the weight band and the age. There is a history of viral fever, malaria, URTI at the time of testing or any other opportunistic infection during the time of testing of viral load. ARV drug, adverse drug, iris are mistaken as treatment failures. Incorrect adherence calculation. I think most of the counselors and everybody knows how to calculate the adherence. So in many cases, the adherence mentioned in the white card and reported by patient varies. Sometimes patients say कि मैडम मैंने तो दवाई पूरी खाई है, एंड कभी कभी क्या होता है कि पेशेंट अपना पिल निकाल के कहीं साइड में रख देता है और वो पिल बॉक्स एम्प्टी पिल बॉक्स आपके पास आता है एंड यू राइट 100%. सो यू नीड टू हैव अ 1-to-1 more counseling session with the patient, because at the times patient does not want to take the ART. Frequently the patient confess about poor ART adherence. Like in PLHIV there are, according to the weight one, there can be 3 tablets, 2 tablets. So in front of the CSUB, ART team needs to address all possible issues to ensure proper adherence before referring PLHIV or CLHIV to SACEP as a treatment failure case. There are delayed referrals. Patient is referred very late and is an advanced immunological failure due to the following lapses at ART center. The CD4 and the viral load, which is not being done regularly at every 6 months. delay in repeating the viral load after the 3 sessions of step-up adherence counseling. Patient does not attend SACEP on the date of appointment. In case the SACEP decision is not received, ART center should follow it up proactively. So what are the incomplete documentation? There are incomplete documentation which we receive in white cards. Like PLHIV will transfer from one ART to other ART center. It is mandatory to give the white card with the transferred out forms. ART start date remains the date at which the ART was started and not the date at which the CLHIV joined the new ART. So in this, the ART is being continued because at many times, like a patient is transferred from one place to another, the ART initiation date will be same with when the patient was started on ART, not when the patient joined the new ART center. When the ART regime is changed, stopped, transition, white card entry of the regime with date should be made in column number 6 of the white card, the antiretroviral treatment summary, the substitution within the first line, switch to second line, any stop or restart, and there should be a reason mentioned for it. It is essential to clearly mention the HBsAg status in these clinical notes. This report will impact the selection of the new ART regime. So the column number 4, which you can see in the white card, like yeah, history is very important, but in many times it is incomplete. You can see like in this the card where ARV was received or not. If yes, when was it received? The PPCT, the ART, the PEP, and the PrEP. Initial CD4 count and name of the place of ART. The patient is taking from private, government, or NGO, name of the drug and duration. This is a very important column which we need to fill and it is incomplete at times. Frequently, PLHIV takes ART from private before coming to the program. It is essential to document details of past history of ARV and CD4 and viral load reports. The challenges we face, the summaries received are especially not up to the mark. There are some sketchy description, incomplete information, growth parameters are not recorded and provided. Sometimes there are proxy written, it is a dash written. There are patient who's coming and taking pill every month and the patient's weight and height is not recorded, adherence not reviewed, patient not reaching on the scheduled time, patient are not accompanied by the caregivers at time, patient have not been adherent to the first line. Reinforced counseling could have been done by the referring center. Feedback not received about the patient progress after a SACEP. So this is you can see, I'm giving example. That is a reply and referral form that we receive for the SACEP. So in this, they have written the, you can see the center which they have referred to us, like the doctor at Kalavati Saran Hospital, the referral date, the Center of Excellence or ART Plus Center. I would like to refer this patient for this. They have mentioned the suspected second line failure, the name of the caregiver, address and phone number were mentioned. So the you can see the summary in which there is not a proper, at least a small case history should be there. And what was the pre-ART, ART, suspected treatment line failure, like the patient has written, the patient was taking ZLN pediatrics, and then the patient was switched to ZLE. Why was the patient was switched to ZLE? And then again, patient was substituted or switched. We don't know in this. The patient has gone into ALD. So we've changed from ZLN, ZLE, ALD, but we don't know this was the transition, substitution, or any toxicity from the drug. And the summary of the adherence history and other psychosocial issue, the adherence is shown about more than 95%. And in the summary of relevant lab investigations also, there is no clear history, like the CD4 baseline and everything is mentioned in this. And the checklist, which I had to give advise everybody to before preparing a case summary for pCaseP, the name is given, the date of birth. At many times in this, so at least we have received the date of birth. Many times in the white card plus the summary, we don't receive the date of birth only. And the mode of, sometimes the mode of transmission is missing. Sometimes the status of the family is unknown and we're not able to know the mode of transmission. How is it transmitted? Sexually, mother to child, and many more details. And what are the, in this you can see at the time of registration, only the age, the clinical presentation, it is written good, okay. And anthropometry is missing, the CD4 count, the clinical staging is there, but the anthropometry is missing. So we don't know at the time of ART initiation what was patient's weight, height, it is no baseline parameters has been sent to us. And the date of ART initiation, we have received the regime. And in this, the patient was switched to ZLN to ZLE. The patient was virologically unsuppressed. where was the patient referred, SACEP was referred where, and all the details with the SACEP is not mentioned in this. Anthropometric is still missing in this, like the weight for age, height for age, BMI with the Z scores, or any other relevant investigations are missing. And this is the white card. I'm showing the example. I've hidden the details of patient and the ART center from where it is from. So in the white card also, the white card is not clear. Sometimes we receive a very sketchy white card. There is rough work done on the white card. So you can see the white card is not clear in this. The column number 1, which is filled, not fully filled, you can see the mode of transmission, everything is filled in this. The column number 4 and the 5th main, the clinical and lab investigations are missing. What with there are only 2-3 entries which are being done, and then there is an arrow mark. So you can see from the white card only we are not able to get the proper history. Why with the drug substituted, the weight, height, and everything is not clearly mentioned in this. Any TB, any opportunistic infection or any TB infection, and this we'll continue in the white card only. In the white card, you can see proxy. The weight is not only the at the times we receive only weight, and there is no height recorded, no BMI, no clinical staging, and no functional stage. Is the patient being ambulatory, bedridden, any CPT profile access, any other IPT? There are no there are no number of pills remaining, adherence, and forest positive symptoms. Any other note which is not there. So you can see from the white card, it is very difficult for us also to get the history out of it. Why was the patient substituted, transition from one drug to particular drug? There are adherence which is not mentioned at the times from the white card, and there are you can see in the last one, the investigations are not also completely mentioned in this. So I will show you one a good practice with complete details. Like in the referral form, we have mentioned where we sending the patient, the referral date, what was it for the alternative first line or a suspected treatment failure. In this, we were suspecting a treatment failure. We've given like name, the proper address, the current age, gender, the ART number, the contact details of the patient. We have attached, you need to attach this with the photocopy of the treatment record, photocopy of all the lab tests, including CD4, any other photocopy of relevant material, address proof with photo. So we've attached the case summary of the adherence attached, including the case summary. The CD4 and viral load also we are attaching with this. So in the summary, you can see properly there is name, date of birth, present age, the mode of transmission, the family history, like in this mother negative, father negative, mother positive, and every detail is mentioned clearly. The date of diagnosis, the place of diagnosis, when was the patient came to that ART center, where was the patient registered, the ART started, the regime, why was the patient substituted to, like from ZLE, the patient started, and from that हमने इसको ZLN पे substitute करा. Why were we substituted? Because we had to start the ATT with the proper age mentioned, like at what age we started on which age. And then why did we switch to TLD with the proper age? And why were we switched to it? Because there was virological and immunological failure also. Where were the pieces of the SACEP done? The baseline parameters at the time of ART, the CD4, the clinical stage, weight, height, BMI, everything is mentioned with the proper Z score. And then all some short clinical summary and the ATT details and everything is mentioned with all the OIs, any OI the patient had during the ART course. And from the second, we continuing the slide. In this, we can see the proper date, the weight, height, BMI, CD4, and adherence. From this, it is clear, and there are no sketchy description, and proper details are mentioned that why we substituted the patient, why we switched the patient from one drug to the other drug, where was the patient being referred for the SACEP, and the viral load details with the proper adherence and the date is mentioned. The patient recent investigation with the CD4 counts. All of the other things are mentioned clearly in this summary. And this is the white card which you need to fill completely, because at the times we don't get proper uh, checklist made in the summary, in the reply and referral form. Like in this white card, we've marked the differentiated care packages we have for patient, like A plus, B, and C. This patient is B. So this patient is virally suppressed. The proper HIV registration number, the pre-ART, ART number, the start of ART, the name, the first identification data is mentioned properly. the mode of transmission, the family history is mentioned properly, and then the clinical and lab investigations are mentioned properly, like the patient had TB or any other WHO clinical staging of stage 3 is mentioned properly, and any enter 6 point like antiretroviral treatment summary. What is the patient current regime? Any date substitution we have mentioned clearly. Tuberculosis treatment the patient has taken, which type of is pulmonary, extrapulmonary, the category, the date, and everything is mentioned clearly in this white card. Even if sometimes there are some missing items in the referral form, we can easily collect it from the white card if the white card is complete and clear. And then the investigations are also properly mentioned in the investigation column. All the investigations like is mentioned like baseline after 6 months and after 1 year, everything is mentioned in this complete white card. And in the adherence also, there is properly mentioned the date, weight, height, the functional status, and the opportunistic infection patient is having, patient is on sepran therapy, the patient is given IPT or not, the status of the patient, if the patient is stable, unstable, the ARV regime is properly mentioned, which regime is the patient on. So like this patient is on ALDTG, this is clearly mentioned. The duration of dispensation, the adherence is properly mentioned, or any other medication described. The forest column is also mentioned clearly, the positive, negative, the TB regime or any other remark we have had. So the white card is clear. Like sometimes when we don't receive the referral form clearly, we can collect the information from the white card. The key points. So, suspecting treatment failure and ruling out OI, IRIS, and ADR in pediatric patient can be challenging. So, we need to have a PCSA for that. Ensure that the patient has been on optimal ART for at least 6 months before sending a referral. Poor adherence is a significant factor for treatment failure in children. Thus, good adherence support is important before switching the patient on second line treatment. And there is one more thing important. At the times, we cannot disclose to the pediatric population about their HIV status. So, the parents or the caregiver need to be counseled very thoroughly about it. Growth flattering, poor adherence, like growth flattering is a sensitive indicator of treatment failure. Does the growth monitoring using WHO growth charts, as I've mentioned before, the WHO Anthro Plus, and there is an app also from which we can we can plot. There is IAP and WHO growth chart is mentioned. It is very easy. You just had to mention the date of birth, the date of presentation, weight, height, and you'll get the IAP or the WHO Z scores for that patient. Chart should be regularly done to pick up the clinical failure. A thorough case summary as per the checklist is important for the PCSUB evaluation, and making a right decision is very important because as I've told already in the slide that we have a very limited ART therapy for the children. So thank you for the session. Any question or any doubts in the session?
Thank you so much, ma'am.
Yeah.
Ma'am, we have a question in the chat box. If a patient fails on ALZL plus lopinavir ritonavir with weight less than 20 kg, now can we give ZL AL plus DTG 10 mg? In presentation, it shows continue on the same regimen.
Patient
Neetu
fails
Gupta, ma'am,
on
would you like to ask your question? You can unmute your mic.
Hello,
waitlist.
Yes, ma'am.
Yeah,
I'm Dr. Neetu Gupta. I'm a senior
yeah,
medical officer from ART KGMU.
yes, ma'am.
Actually, if patient is failing on ZL, like suppose patient is failing on ZL lopinavir and weight
Yes,
is
ma'am.
less than 20 kg, we can
Hmm.
switch the patient to AL and DTG 10 milligram now. DTG 10 milligram is available now.
Digit 10, yes.
So,
If
but
patient is
I
failing, the
think
viral
that
load is suppressed. Unsuppressed for
yeah,
how, like,
no, I'm saying the patient has failed. Two viral load greater than 1000 copies per ml, and we have
yeah,
from SACEP actually. So, and
okay,
if the patient is failing on ZL and lopinavir, so
yeah,
we'll switch the regimen to AL and DTG 10 milligram, isn't it?
yes. And for the ZL
And
substitution,
presentation,
if the patient was an AL and you are substituting it to ZL and DTG, you need to check the
yeah,
patient hemoglobin, the current hemoglobin. If it is
yeah,
more
yeah.
than 9, you can
That
switch it to ZL. Otherwise,
actually
continue on AL.
the presentation you showed it said they continue the patient on the same regimen. That is the old one regimen, I think,
Yeah, that is
when
the
we were
old
not
one.
having the
Yeah, that time we did not have DTG 10 mg. Now the DTG 10 mg has been come in the
presentation is that
program.
one.
Yeah.
That's where that's okay.
Any more questions? I'm open for the questions.
Any more questions from the participants? Please feel free to unmute your mic.
Yeah, Swetaji, I think ma'am is right that that was the old regime that was there in the slides.
Yeah.
So the patient is sitting on ZLLPR, then the alternate, now the DDG10 has come. I think the slide needs to be corrected. I think that's one mistake. And
Yeah, that needs to be corrected in the slide.
yeah, that needs to be corrected. Yeah,
Yeah, so we'll get it corrected before circulation.
yeah, please.
Right? Thank you.
Yeah.
Any more questions? Ma'am, I don't think there are any questions. Thank you so much for facilitating this
Thank you.
important session.
Okay. Shweta,
Yeah,
I want to
yeah,
mention one thing
Swetaji,
important.
yeah.
For the referral, it is very important for the any SACEP for adult or a pediatric patient. The referral summary needs to be very clear. The white card needs to be very clear on all the checklists should be maintained because we have a very limited drug option for PLHIV and CLHIV both.
Yes, absolutely, ma'am. I think that's the most important thing. The RRF
Yeah.
forms must be, complete.
Yeah.
And the white cards needs to be complete. Unless the details are correctly laid down, it's very difficult for any SACEP, whether pCoE or adult SACEP, to
Yeah.
take a decision. I think that's most
Yes.
important for all the ART centers and the ARTC centers. Now it's mostly the tele-SACEPs and e-SACEPs that are happening. So unless the
Yes.
correct information is not provided, then I think
Provided
for
to
the
the
export is
center.
very
Yeah.
difficult.
Yeah. It's very
Yeah.
difficult for a COE or a pCoE or a ART
Yes, yes.
plus center to decide about it. The drug therapy.
Yes. Exactly. Thank you so much, man. That was a wonderful.
Thank you.
Shweta,
Thank you so
over to
much.
you.
Thank you.
Thank you,
Thank you
sir.
all. Thank you all for listening to the
Thank you,
session.
everyone.
Thank you.
We'll
Thank
conclude
you.
the session now.
Okay. Thank you.
Shikha ma'am, any question? Shikha ma'am? Okay, no question.
No, ma'am.
Yeah. Okay.
No, ma'am.
Okay. Thank you.
Okay. Thank you. Thank you so much all. Thank you.